in 314 for a shooting at Century Theaters. They're saying somebody's shooting in the auditorium.
Roger, keep your fires west of the smoke. You're cleared hot. An officer hit. Send me the world.
Don't go over that fence. Don't go over that fence. Grab the shotgun again.
Welcome to Tactical Tangents.
Hey, welcome back to Tactical Tangents. This is Mike and Jim. This episode is brought to you in part by Ride-On Optics. Ride-On is bringing you high-quality scopes, red dots, and binoculars at a great value. Their products have an unconditional lifetime guarantee, so you can buy in confidence. Ride-On is a law enforcement and veteran-owned company, so go show them some love at rideonoptics.com. Tonight's guest is a guy named Mike Lauria, who I crossed paths with years ago when I went through a portion of the Pararescue indoctrination course. And for the sake of transparency, I always think it's important to remind you that I did not finish that course. I was never a PJ, but since my time there, I've done a fair amount of reading on things related to decision making and working under pressure. And I know those are themes that are common in this show. And I've often found myself referring back to several of the lessons and the mental representations that I formed during my time there. And it's helped me learn, and it's helped me teach and perform better in the jobs that I've held since then. Fast forward to a few years ago, I stumbled on an episode of the MCRIT podcast, which is a show that we like and we endorse. And
it's one of my favorites, straight up. Like, it's one of the things that got me into podcasts was listening to the MCRIT podcast.
Yeah, and so we're a fan of that show, and Mike was on. He's been on several episodes, I think. I'll let him get into that. But there was an episode I was listening to, and I found that he seemed to talk about several of those same themes that I am also interested in, but in a way that was much smarter and much more articulate than I could ever hope for. So I thought it'd be cool to bring Mike on the show and to talk about some of those things and reconnect with him. So Mike, thanks for being here.
Oh, it's a pleasure for having me, guys. Thank you so much.
Awesome. So you've been a lot of places and done a lot of things over the years. Can you cover a little bit of your background for the sake of our listeners?
Yeah, absolutely. No problem. So I kind of started out my career in emergency services. Actually, right around the time I was in college, I actually lived at and worked in the fire department for a while, about 4 years or so, 3 or 4 years. And then I finished my undergrad at Dartmouth, and like any level-headed 21-year-old, I decided to enlist in the Air Force and do the PJ thing, which worked out pretty well. Really enjoyed it, had a blast. I was at the 321st Special Tactics Squadron for most of my career. And then I decided to get out. I spent a year kind of finding myself. I worked with a company called Tier 1 Group doing training, primarily medical, but also some weapon stuff for various special operations teams. And then what I realized was I actually really missed the clinical side of things and actually providing care to people. So I moved back to what I consider home, which is New Hampshire. I got a job flying as a flight paramedic. And then had several faculty physician mentors there who were like, hey, you know what? You should stop being such a wimp and just like bite the bullet and take the MCAT and try to go to school if you really like this stuff. And so I did. I went to medical school. I graduated from Dartmouth Medical School in 2018 and came back out here to the Southwest in Albuquerque for residency in emergency medicine.
So that's badass.
Yeah, pretty impressive resume there. And as far as I mentioned in the intro there, the decision making and working under pressure, and I might have jumped to my own conclusions when I've heard some of the other work that you've done. Am I understanding correctly that those are things that you have an interest in? And if it is, can you talk about where that came from and what the big takeaways for you have been?
Yeah, absolutely. So, in general, I guess my area of interest would lie in the domain of what we call human factors and human performance. So, human factors, my, shall we say, elevator pitch definition of human factors is basically understanding how human beings think, how we act, how we communicate with one another, and how we perform technical skills in in very high stress situations in particular. And I sort of got interested in that because what I noticed was that all of the book stuff, all of the things you learn in these very dynamic, very high-risk situations are totally different. And what I realized was that, and absolutely fascinated by, was that some of the most elite tier 1 operators on the planet understood this. Some of the best trauma surgeons and anesthesiologists I had met understood that. Some of the best pilots I had ever met understood that. And the list goes on. And what I noticed was these common threads across all these different like high-risk occupations and domains where people had either academically explored and researched and studied this stuff, or they had like naturally adapted various skills to make better decisions, perform technicals more effectively, all sorts of stuff. And I was like, man, there's a really cool common thread here. And in particular, one of the things I noticed though is that in medicine in general, there was a lack of attention to this. Yes, I mentioned there are some trauma surgeons and anesthesiologists and other people around the world that sort of picked up on it. But interestingly enough, most of those guys were pilots, or they had been in the military, or they had had exposure to other stuff. And I was like, man, in an occupation where we're dealing with people's lives on a regular basis, this is a very high yield topic. And so that was sort of how I got into it.
That's interesting. Friends of mine who work in the medical field have talked about the book, Why Hospitals Should Fly, sort of applying crew resource management from aviation into medicine. Is that a book you're familiar with, and is that kind of along the same lines?
I am peripherally familiar with that book. I have not read it cover to cover. It is along the same lines. The problem is that I think very often people in medicine kind of have these great ideas, and they really, really are great. But when they get these great ideas and have no experience or training, like in the human factors realm, then they just kind of draw these direct analogies like, hey, you know what? Like, we should be more like the airline industry, or we should be more like aviation, which is true in a sense.
There are crossovers, but you have to navigate those crossovers well. Like, I think that's exactly what we try to do here is, balance between the tactical side and the aviation side and the medical side. There are definitely parallels, but they ain't the same.
Right, exactly. So you have to like adapt them appropriately as opposed to just draw straight lines. So if I could, one of my pet peeves, one of my all-time pet peeves is people read the book, for example, The Checklist Manifesto by Atul Gawande, and have tried to say, oh, you know what, our ICU or our emergency department or our whatever needs to do checklists. Right. And so they basically read the book and then they try to develop lists, true, with lots of crap on them, also true. But really, when you think about it, what Gawande is recommending and basically the layout of his book is accurate, but it's totally different in emergency settings. For example, in the human factors world, we have two totally different types of checklists, right? We have emergency checklists and we have routine, or what we call normal checklists. And Gawande wrote a book basically about the application of normal checklists for surgeries and things like that. But in the real world, we design emergency checklists totally differently. So it's really kind of interesting that without any sort of attention to this or any academic discourse in this area, people are just like, oh, hey, Atul Gawande says it's a great idea to make some checklists. So let's make a checklist, an airway checklist for our emergency department.
I remember, and I don't remember if it was that book that I read it in, because I read Checklist Manifesto, and then there was another book that I think it probably actually, it was right around the same time I read it, so I can't keep the title straight in my head, but there was one that talked about it's not just the checklist, it's dealing with interruptions of the checklist. That was one of the things where, and the example that it gave was in a surgery, for example, or a blood transfusion scenario, it's on the checklist that you need to verify the blood type. It was if you had to stop that checklist to give attention to something else and then you jumped back into it, remembering which step you left off at. That was like one of the key parts of it. And I think that kind of speaks to what you're saying about routine versus emergency checklists. Is that fair?
Yeah, that is definitely a totally fair point, because people ignore those like behavioral implementation aspects of it. So like, yeah, there's much more nuance to it, like how you get interrupted, right? Or actually even things is like how you lay out the checklist, like what size are the font, what, are they all capitals, how that font is organized. Actually, we debate very closely about like the precise wording of the checklist, how many items should be on it, right? Like there's a lot that goes into the design. And if you like talk to anybody in a major airline that actually makes these, they go through multiple iterations, and it's a much more nuanced process. So what I try like tell medical people, for example, is it's not just like, if I were to give you any surgical procedure, like a damage control laparotomy where you're trying to stop bleeding in someone's belly, like, yeah, absolutely. You just cut open their belly basically, and then you stuff some stuff in there, and then you close it up, right? Well, obviously, not
step one,
right?
cut
like
belly.
You have it is a relative. I'm not a surgeon, but talking to my surgical colleagues, it's a relatively simple procedure compared to many more complex procedures in surgery. But it's still not that straightforward. You need lots of training, and it's nuanced. And to do it quickly and effectively, like it takes repetition and training and focused, deliberate practice, right? So there's like a lot more that goes into it, and I think that often we fail to appreciate that.
Oh yeah, there are tons of different little segues we can take off of this. This is kind of the core of what we're about here, so I'm all excited and jazzed up over this. One is, and I'm a pilot, so running checklists is like a lifestyle. So on one hand, there's just different ways to run checklists, period. And there are different communities that take those, and more or less seriously, and in some cases, like the getting into the airplane checklist. Well, you're not sitting there staring at the checklist saying like, okay, put on my seatbelt. Okay, turn on the lights. Like, you're not doing that. Right. There's a flow, and you're just kind of flowing around the cockpit, getting stuff done. And then there are times where you're doing something weird, maybe something you only do once a month or, once every 5 flights, whatever. And then you bust out the checklist, you look at it, and you kind of finger drag your way down it. And then there are times to sit there and read verbatim, okay, handles pull, trigger squeeze, off we go. And simply saying
that's
do
another
the checklist doesn't help, right?
Is that some of those checklists are designed and you guys use them like in a flow style, right? Where you just like basically like go through, you're like running your finger down, making sure everything's good to go, because you've done it like a million times and it's like a little more routine, or potentially like a little less high risk versus like very specific procedures. Likewise, what I think is funny, and this again drives me nuts, is it's all over the map, right? Like, have you ever, is there like a checklist for like opening the door to the plane? Right?
No,
or
but on
like,
some airplanes there should be.
Is there any like checklist that like, discusses, or like the beginning of like a checklist that discusses like adjusting the seat in like the aircraft? Like there's some things that are so detailed and so simple and so routine and benign that you just don't put them on the checklist, right?
Yep. Yeah, and there was a management philosophy for a while that said that is how all management should be. Like, if you're going to host a meeting, you should have a checklist on turning on the lights in the conference room and turning on the PowerPoint projector. And like, you can, especially the military, we can go crazy with that. And then I'm gonna jump around on you a little bit. You talked about the human factors of the checklist itself. I thought that was a great point on, we're trying to go all electronic. We're trying to go to iPads and electronic flight bags. And it never occurred to a lot of people that flight gloves don't work on touch screens. And so we had to go buy gloves that would work on it. We'll take our gloves off, and that, that ticked off safety guys who were concerned with fire danger. And like, there were so many layers of thinking that had to go into everything that we did with moving the checklist over. I thought that was a great point. And then I'm going to segue us again. There's so many things to talk about. The ABCs in March. Right, like that's a checklist, massive hemorrhage, airway, breathing, circulation, whatever. And like, you can't just hold that checklist in front of you. And even if you did, it wouldn't do you any good, right? You have to understand it on so many deeper levels of what you're trying to do. And can you speak to that real quick?
Yeah, I mean, so I think there is a little bit of a difference between some of the mnemonic as cognitive aids that we use and like a checklist. In a sense, I guess you could consider like ABCs and March kind of like a checklist. But really, as like those mnemonics are designed to be like an aid memoir, like a memory aid, and like the basic fundamental steps and things you should be hitting along the way. But like you pointed out, like there is a lot that goes into those type of mnemonics, in particular cognitive aids, because you've basically like compressed a lot of stuff into like a short 5-letter mnemonic like March, right? But it requires a lot of training and a lot of education to understand like what those individual steps are and what you need to do. And it's obviously much more complicated because, like, for example, the M in airway could be like actually very complicated, or it could be very simple. It could be like a nasal pharyngeal airway, or it could be a very complicated airway that you didn't anticipate. Likewise with hemorrhage control. Dude, I know there are plenty of medics who have been out there, especially in combat, who, you train and train and train with like tourniquets and junctional dressings and some of these other devices, and it's like no problem. And then you hit like a really nasty like junctional hemorrhage. It's like almost impossible to control. And despite like working really, really, really hard and like using every tool in the toolbox, it's still not great.
Yeah. And so for anyone who's not tracking with some of his verbiage, if you watch the movie Black Hawk Down, there's a scene where a guy got shot right in the groin, right? And the medic is trying to get in with pinchers, forceps things, right, to try to clamp it off, and it keeps not working. Everything he tries just doesn't work. So if you picture that in your head, so along those lines, given your background, can you speak to like the level at which a 19-year-old Ranger needs to understand that mnemonic versus an EMT or professional medic, IDMT type, or PJ, versus an ED doc versus like a trauma surgeon? Can you speak to like how that mnemonic applies across,
like scaling it?
But there's a difference, right, between the way you understand it now and the way you understood it, going through Kirtland and on and on.
Yeah, absolutely. And I think you guys hit the nail on the head. Is basically scaling it to the environment, to the mission, and to your particular capabilities, right? Because at the University Trauma Center, the mission is the trauma resuscitation. You're generally safe. Like, there's no one, well, depending on where you're on. Maybe in Tucson and Albuquerque, there's a little bit higher risk of someone actually walking in the trauma bay and like it turning into a combat zone. But yeah, well, for purposes of this discussion, we'll consider it meta-safe. You're like, everything you're doing is focused on basically fixing the problem at hand, whether that's providing definitive airway management, temporizing a hemorrhage or bleeding until you can get to the OR. I mean, whatever it is, that's all you're focused on, number one. Number two, they're really not going anywhere else. Like, you're the show, right? So everything you're doing is predicated on like them not going anywhere or needing anything else. It's your toolbox that's going to fix the problem. That totally changes in like the deployed environment. It changes in the operational law enforcement and civilian environment. It changes if you're on the side of Mount Hood or Denali, or in a small outside emergency department where you have some tricks and tools and available to you, but you may not have like a trauma surgeon. You may not have a vascular surgeon. You may not have certain facilities that you need to perform certain procedures, right? So it all depends. And scaling, like you said, is really, really important. When it comes to scaling, I think the interesting thing is you need to have a way of applying these things in a particular environment. So like a mantra or an overarching philosophy, right? Because just like we have big picture, like guiding strategies, and then we have tactics, and then we have individual techniques, like the step-by-step way that we go about doing things, it's similar. And to me, like the ABC stuff and the March stuff are like the tactics, but the overall like big picture strategy is different. So I'll give you an example. So the way I apply like the March stuff in the field, or think about it, like my mantra in the operational environment is like, you know how like for CQB, like our mantra is basically speed, surprise, violence of action. Those are like the guiding, overarching strategic principles of what we're trying to accomplish. In the tactical medical environment, I think about basically in a similar sort of way. I think about speed, I think about simplicity, and I think about coordination of care. In other words, if you were to take the March steps, massive hemorrhage, airway management, respirations, circulation, and then depending upon who you are, who you listen to, your head to toe exam, hypothermia, head injuries, whatever, however many H's you want to multiply.
March.
Right? Yeah, exactly. Speed would be like in that operational environment, speed is security, and you are trying to do things as quickly as possible. The BS that we tell people, like slow is smooth and smooth is fast, is ridiculous. It's not. Like slow is just slow, right? You want to train to the point where you're moving and you're basically utilizing economy of motion to optimize and make those individual steps, moving from massive hemorrhage to airway management to all those things as quick as possible. You're trying to keep it as simple as possible, right? You're not carrying with you like a whole operating room worth of tools, right? You're not taking a cricothyrotomy kit to perform a surgical airway that has like 34 different surgical instruments in it. You're using like a scalpel, a finger, and a bougie. It's pretty simple and straightforward. And likewise, coordinating care, because you're not the end all be all for this person, right? Like you have to stabilize them, get them medevac, get them to definitive care, and ultimately like a hospital back in the United States. So coordinating, communicating with people like what the next steps are, and then deciding like, you know what, like if the helicopter's gonna be landing in 30 seconds, maybe now is not the time to do X, Y, or Z. Maybe I like throw this person on the helicopter and then I'll actually do these other steps, right? So that speed, simplicity, coordination of care is like my mantra, my principles, the overarching strategy, and that determines how I employ like my March or ABC stuff. Does that make sense?
Yeah, it makes a lot of sense. And what I love about it, you kind of you beat me to some of the things that I wanted to bring up because, and I'll use March as an example. When I take a rookie cop, and I start talking about tactical medicine stuff, and I start going through, hey, this is March, and we kind of talk about the tactics of tactical emergency casualty care or whatever. That's all great, and I think it's good that you point out that it's a cognitive aid, not necessarily a checklist, because what do we know when the adrenaline hits, right? They lose all their IQ points, they see a lot of blood, and then all of that stuff that we've taught them that cognitively they understood, if I sat them down and talked to them about it, it all goes out the window. And so having this overarching thing where you can go, okay, let me bring back a little bit of focus so I can start to get the thinking side of my brain working again. And that's the only time that March stuff is going to start to be helpful to me, is when I can get back to that state of mind. Mm-hmm. So my next question to circle us back into human factor stuff is, what are the training implications? How do you take that mantra, that philosophy, to teach a new guy in any of these fields, whether it's emergency medicine or anything tactical, law enforcement, military, anything combat type of related? How do you teach that guy how to stay calm and collected under stress and apply this stuff?
Yes, that is a fantastic question. And it is basically the topic of a book or like multiple lecture series, but I'll try and distill it down. First and foremost, like it starts with like the fundamental skills, which I think is important to mention. Most people I think would say, oh, it goes without saying, but it actually doesn't, because if there's one thing I see very commonly, it's people rushing through the common skills, or sort of like just talking through important things without really going into them. Like I'm always surprised when we teach new emergency medicine people, whether they're paramedics, whether they're flight nurses, whether they're residents, like we go over like these higher like intellectual discussions about drugs to put people to sleep and paralyze people, and all kinds of crazy discussions about physiology and whatnot, which is good. It is important, right? But if there's a person who's never intubated someone before, like we skip over very often like the fundamental mechanics of like how you use a laryngoscope to like actually intubate someone or put a breathing tube in, right? You know, and people would say like it goes without saying, but it really doesn't, right? And when you talk to a lot of airway people who are like really, really good, they will say like many, many tacticians or pilots who are really, really good, like the basics, the foundational stuff are of the utmost important. And we skip over that. So I can't emphasize enough, like building fundamental critical skills in a not stressed environment is step one.
Yeah. One of my favorite things about special operations is it's not about doing the weird stuff. It's about getting the fundamentals right, even when things get weird.
Yeah. That's actually a really good way to put it. I might use that one. That's actually really good. The next part is like, once you have like the puzzle pieces built, like the individual blocks, the building blocks, I would say, with these critical skills. The next step is to think about like the environment they're going to have to be performed in based upon like what their job is or how they're going to be functioning, whether that's in the field or in the trauma bay or in a foreign country somewhere. It also has to consider like what is the physiological milieu that this person is going to be experiencing when they do this skill. For example, like doing a surgical airway or like close quarters battle. These are things that what we call like the reactionary gap or the cognitive processing time is so short because things happen so quickly that guess what? Like you cannot teach like a 34-step procedure for that particular event. In fact, we know like the simpler the procedure, the more straightforward, the less like higher cognition you have to entail in these situations or to use in these situations. Basically, we know that people perform better in general. Also, so like you come with those times when like when time is so scarce and the potential risk is so high that you're teaching people to think less and act quickly and decisively more. There are the other times when you have to teach people to like downshift, right? Take a breath or take a deep breath, think about it because you have a couple minutes or you have a second or two before you move across like a street to another building, before you actually take this patient up to the ICU, before you do certain things where you have some time to actually stop and really analyze the situation and think about it logically. And so that's the opposite side of the spectrum. But then you like fill in all those spaces in between where you may or may not have more or less time. You may have some more interventions or things you could do somewhere in there. There's time for discussion and debate and whatnot. So teaching that. And then finally, I think the last step is really, really honing things. And this is basically training tacticians, SWAT operators, special operations personnel in the military, pilots, NASA, astronauts, doctors, medics, you name it, to basically understand like psychological skills and performance psychology, which is sort of like the icing on the cake. I think it's really interesting that athletes or organizations will pay a lot of money and actually really explore these topics. And very seldom in, say, like medicine, do we actually apply performance psychology to resuscitate, like life-saving resuscitative procedures. So I think that's like the last step.
Yeah, and you mentioned earlier the common threads thing, and that was something that, I mean, I think even back to my time at NDOC, and we had the psychologist that came in and did the training every week with us, and that imagery stuff, and the common thread that as I started to get into law enforcement and learn about training and the behavioral stuff as it applies to training. And there was always those parallels, not only to medicine and aviation, but also to professional athletes. And there's so much money and so many resources in that field that we'd be fools to not take advantage of it, right? Like some of the best shooters I've ever met, the first books that they would recommend were things that related somehow to sports psychology stuff. And that was another place that I think you can get a lot of good info if that's something you're trying to research. Anyone that's listening, those those books and those fields, you're going to get those common threads. And I think that's a big part of this.
And there's a caution here, right? That again, if you're just going to apply cross domain, you have to do it thoughtfully, right? So some champion marathoner eats 85,000 calories a day. Well, I'm going to train like a champion. I'm going to eat 85,000 calories a day. No, it doesn't apply, right? Some Navy SEAL holds his gun a certain way. Well, that Navy SEAL is 225 pounds of twisted steel and sex appeal, and he can do that because he's got the muscles and the levers to do it. I don't. I'm going to hold it a little closer into my chest, right? So, you have to do it thoughtfully.
Yeah.
You mentioned human factors, and in aviation, when we think human factors, we usually think man-machine interface, right? Laying at the cockpit in a more intuitive way so that my eyes are looking where the information is presented where my eyes are looking. I can control the airplane through my hands without taking them off the throttle and stick. Can you speak on the medical side about man-machine interface? And is there something that needs to get fixed on the medical side as far as the equipment that you work with day to day, or how it gets laid out on the table, anything like that?
Yeah, so I think that's an important. I think that is a very important point, and there is again a lot of room for improvement on this in medicine in general. And I'm really glad you brought that up, because I neglected the other piece of human factors, which most people refer to it in the academic discipline as, or the academic discipline of human factors and ergonomics, or HFE. And
Yep.
I focus primarily on the human factors because I'm interested in the cognitive behavioral aspect of things. But I'm really glad you brought it up, because the other piece of that, the ergonomics of like how you set things up and how you interface with technology, or how you interface with equipment, or how you're positioned in a cockpit, or how you're positioned around an operating table, are actually really, really important. And again, it's something that we don't always think about. I mean, yes, I think the senior clinicians are very well aware when they set up like an operating room of where they stand, so they're facing the screen a particular way, or an intensivist, someone working in the ICU, or someone working in the ED, when you're trying to place a large IV catheter in a big vein in the groin or the chest or the neck, setting up your ultrasound equipment so that you're actually looking in line with the ultrasound machine, right? That is like step one, but it goes like way beyond that. And in fact, when I look at some of my mentors and people who like really have this down, they look at it the same way as like our special operations personnel look at like exactly where they put their magazines on their body armor. So like they can reach down in the middle of the night blindfolded or just plain blind, and they know exactly where all their equipment is. It's so natural that reaching down and grabbing another magazine and reloading your weapon system is like breathing. It's like flawless, where like exactly like on your hip, a couple inches in front of your hip, a couple inches behind, like up or down, like you actually have your sidearm, makes a big difference sometimes in how you engage that weapon system when you pull it out of a holster. And when I see the same thing in the medical arena, people in general think about it like, Joe Schmo going to the store and just buying like a holster and thinking about, well, I just gotta pull this thing out of the holster, without considering like all those aspects of things.
Simple as
Same
that.
thing in medicine. Yeah, like same thing in medicine. You see people like set up their airway equipment, just like lay it out, but like a smart like really, really good anesthesiologist will, I've seen them basically like set things up the same way every time in a certain specific order, so that they can just like reach behind them and they know exactly where on the tray certain pieces of equipment are. They set it up so that their flow from bagging someone to intubating someone to starting the gas, like when you watch them, it's like watching like a pilot go ahead and start up like an aircraft, or run through like a startup sequence. It's so beautiful and flows so naturally that they have the ergonomics down pat. Same things with some of my surgical colleagues, like when I watch them perform certain surgical procedures, as opposed to what I see more commonly is like there's the cricothyrotomy tray, and you open it up and it's just this mess of like 20 different instruments that you have to go digging through before you get to like the life-saving pieces of equipment that you actually need, right? It should not be that way. It really shouldn't. But just because we think of it, well, this is all the stuff you need. So we'll just like sterilize it and wrap it up in this tray. And then when you're super stressed out and like trying to do 7 things at once, I'm sure you'll be able to dig through like these 32 pieces of equipment and find the one thing you need. Doesn't happen that way. So I think we could do a better job.
That's awesome. It's a great point. We need to take a quick break to give a shout out to Mantis. The Mantis is a firearms training system that gives you shot-by-shot analysis on your shooting. It works on both live fire and dry fire and is the next best thing to having a live coach diagnose what the gun is doing when you pull the trigger. The Mantis is a great way to perform deliberate practice on your shooting fundamentals and will help you step up your game, so check them out at mantisx.com. And what I would say on top of that is it's exactly this sort of thing, is you can figure out your economy of motion, you can figure out your ergonomics because you're getting feedback on it. If I put my gun holster 1 inch forward on my belt, what difference does it make? And you can actually track your data on whether it made a difference, right?
Yeah, and to speak a little bit to what I can only imagine is Mike's background on this, because every PJ I've met, when they show me their kit, like every once in a while, as one of the SWAT medics on my team, we'll get a chance to either train or interact with some of the PJs at the unit that's local to me, and their gear, you see the difference. Like if you look at one of our guys and you open his bag and you look at the way it's laid out when one of the PJs opened their bag, you can tell that they've gone through every prepackaged kit. And like, I'll use the Crite kit that Mike talks about. Instead of the 17 tools you're going to find when you rip that thing open, they've gone through, they've picked the 5 that they want, they've repackaged it some way. It's placed in a certain spot, and everything is laid out exactly the way they want it. And that level of thought, granted, it's not only just well thought out, but you can tell that it's that way because they've used it and they've practiced those fundamentals. To speak to the point Mike made earlier, they've got fundamentals down to the point that this is a very well rehearsed, methodical, thought out, pre-planned process and procedure that they go through. So I've seen that. One thing on that
is I feel like every EMT or paramedic kit I've ever seen is different. Right, and I'd be interested to pick both of your brains on when you want to be standardized across all the kits and when you don't want to be standardized across all the kits, because it's a very personal thing as far as I can tell, right?
Yeah, so that's also another really good point, is that, for example, a lot of PJs that I work with had different kits and they were set up different ways, unless there were certain exceptions to that. So there was certain standardized loadout equipment that was always the same way. In theory, and I would say in practice as well, we see that standardization of procedures and equipment is generally pretty helpful. It's particularly helpful and seems to have benefit where you're working in a system with lots of different people who are accessing the same equipment all the time. So, you could make an argument that, for example, if it was your plane, you only flew your plane, like customizing things a particular way, there's nothing wrong with it. Likewise, if you were the team medic and you were the only team medic with the only medical kit, like if you customize things a particular way, it kind of is a standard because there's only one. That said, like if you're looking at a fire department or a ambulance service or a hospital, it is generally better to standardize things. That is really hard in practice. Why? Because all of the surgeons and all the emergency medicine doctors and all of the anesthesiologists were trained a certain way. They came from different facilities. They do things differently. They're used to different pieces of equipment. One person likes this particular hook. One person likes this particular scalp, whatever, right? But in theory, it would be best if everybody got together and like, you know what? We don't need all this crap in the Crite kit. We don't need all this crap here. We don't need all this there. Maybe we should add this here and just make it standard across the hospital. That would generally be the safest thing. I have to say, more and more hospitals seem to be understanding that and adopting it. So while all of the individual kits, for example, the Crite kit may not be the same, or the airway kit may not necessarily be the same in the ICU, the emergency department, the ORs, and everywhere else in the hospital. Some things are. So, for example, most hospitals have a standardized code cart with like the same defibrillator, the same drawers set up the exact same way in a standardized packing list. So at least in the worst of situations, when there's a cardiac arrest, like if I go around the corner or in this particular unit of the hospital, I know that at least the same basic pieces are there.
Yeah, and I think it's hard to, a lot of those people that are involved, like if you have so much expertise in one room and you try to get them all together to say, hey, we're going to standardize something, people are never going to agree on on a lot of that stuff. So,
well, my way is the standard. Get on board, right?
Yeah, there comes a point where it's like, okay, well, fine. Well, these are the things that we'll standardize, but like I'm keeping my stuff the way my stuff is, and the code card, it's like you got to pick and choose your battles, I guess, in that sense. But
yeah. And to be honest, like I got to tell you, even though I was in the military, like I don't always like following orders from people or being told what to do. I don't like wearing the same thing. I like wearing what I want to wear. Like I don't like. There's a lot of standardized stuff that I'm not a huge fan of. But when it comes to emergency things, I am a very big advocate of standardization. And Mike, I think you brought up a fantastic point. And this is something that, I think is good about the military. We may not always like it, but at least there is an executive hierarchy that'll be like, you know what? We're done debating and having a freaking caucus about how we're going to do this.
Yeah.
This is the way we're going to do it. Like, happy to take input up to a point, but like there is a certain point where you just got to be like, you know what? This is what we're doing. And in some organizations, especially on the civilian side, that is like almost impossible.
Yeah, at some point democracy gets a little inefficient. I know there's certain things that if we have a vote on the tactical team that I work on, you're going to get we're just going to sit there and debate for hours until finally someone shuts everybody up and makes a decision. So so turning more into some of the medical stuff, and I know we jump back and forth because we talk about human factors as it applies in the medical realm as well as the tactical realm. But I want to talk specifically about emergency medicine stuff because you've seen such a wide range of scenarios, obviously tactical stuff, civilian EMS, and then now in a hospital. And did I hear correctly that the ER that you're working in is also a trauma center?
Yes.
It's
yeah.
like
So we're the only
center.
level 1 trauma center in the state.
Legit. So what are, in your eyes, some of the pitfalls that and I guess I need to qualify a little bit what I mean by providers, because let's stick with like maybe not layperson, but let's go with law enforcement and EMS. If we were to limit to that level of provider, are there any pitfalls that you have seen people make decisions on that's like a trend that we need to address?
Yes. I would say there's a handful of things. And given the specific scenario, like law enforcement and fire in the field, in general, like I think about the way that we've conceptualized pre-hospital care, emergency department care, OR care, ICU care, right? As like we've basically categorized, described things, and trained people based on geography. Right. And that is not unreasonable in the sense that those environments are different. But if you think about it, like the pathology, like once someone gets shot and starts bleeding, it doesn't matter whether they're like on the street or in the emergency department or in the OR, like their physiology is still progressing. They're still bleeding. Right. So we think about these things in terms of tiers or steps. And then like what we do, what our protocols say we can do in the pre-hospital environment, what are the steps that we have to do in the emergency department to get this person up to the OR. And really we should be asking like, what is going to matter the most and how do we do that fastest? Right. So, for example, I think, and believe me, like being the super nerd paramedic that I was and still am to a certain degree, like it does like rub me a little bit wrong when people are like, hey, we need to get this guy in the back of the ambulance and go, or we need to just take him and move. But when you think about it, like really, that's what this dude needs. Like 2 IVs and a whole bunch of salt water, like did not fix anybody. Like no trauma patient. Right. So you really like, if you don't get IVs, right? Like, I don't care. Get them to the emergency department. If you can get access, great. Helps us, makes things a little bit faster. But like, just getting access so you can give them like normal saline or some crap is not helping them. In fact, there's some pretty good evidence that it's probably hurting them. That said, you did mention like the smart approach to it. So let's say you have a longer transport, like an hour transport from some of our rural areas, or an hour flight. Yeah, getting access. And if you have something like blood, whole blood, plasma and RBCs, that actually might be helpful. So in those particular instances, maybe you should get going, start some IV access, and then give them the things that matter, that are actually helpful. We've like moved past, for example, for the longest time in many a trauma center, with the exception of a handful around the United States, it was common to, like, in the middle of a traumatic arrest, being given these patients like epinephrine and doing standard ACLS for them. And in a lot of places now, pretty much every place, I'm hoping, I'll make that assumption, have moved away from that. And we really don't do CPR in the setting of trauma arrest at all. We do the interventions that we know are going to be important, helpful, including managing their airway. There's some debate about whether like have to be intubated versus like just put like an LMA or iGel or some sort of supraglottic airway device in. Decompress both sides of the chest as quickly as you can, whether that's needles or preferably finger thoracostomies, chest tubes. If it's a blunt traumatic injury from a car accident, binding their pelvis and giving them blood. If it's a penetrating injury of the chest, gaining access to the chest if they don't have return to spontaneous circulation relatively quickly, up to and including doing like a thoracotomy, are like the primary things now. Right. We try and do those things as quickly and as effectively as possible, because we know that those are probably the things that are going to kill them. And if we have any chance of saving them, we need to do those things really, really fast. And it seems to work. So that was sort of a long, babbling way of saying I think we should be less focused on protocols and doing steps, because we're going to get yelled at or we have to figure out some protocol. We should be more focused on meaningful or time, or reducing time, actually, to effective, meaningful intervention, number 2. And number 3, looking a step ahead and thinking about something as well. It's not just like me treating this person and trying to like check off a bunch of boxes in the field, but thinking about like what this guy is going to need next. He's going to need surgical intervention. So if I can get him warmed up, if I can give him some blood and get him euvolemic, if I can do things that will optimize him to get the surgery that he needs before he arrives at the hospital, that is like what we should be looking to do, in my opinion.
So like thoughtful application of the checklist and not just rote application of the checklist to kind of bring this full circle, right?
Yeah. This is super specific, but since I have you, because you started talking about needle decompression, do you have any insights on the latest research regarding chest seals? This is something that I've been trying to resolve in my own head for a while, because a lot of the new literature that go out to layperson providers is saying not to apply chest seals because of the risk of worsening pneumothorax to a tension pneumothorax, and then you'd be taking it off anyway, and that sort of thing. So I'm wondering at what point, if we're going to see those not be a thing so much.
Ooh, so that is a good. That is actually a very fair and good question. To be honest, I have not done a comprehensive review of all the literature or the science behind it in the last few years. I can tell you the way I think about it is, do I put it on a chest seal? Okay. The way I think about it is, if this person is getting positive pressure ventilation, in other words, like I'm breathing for them, I'm bagging them, I have an intertracheal tube in, I have an LMA in, doesn't matter, right? Because at that point, you are like, if they just had a giant hole in their chest and you're inflating their lungs for them, doesn't matter. So I actually don't in those situations. More commonly, is the person spontaneously breathing? Yes or no? Yes, you mean if the answer is yes. I don't know of any literature that suggests that If a patient is really, really struggling to breathe, putting an occlusive dressing over it actually makes it more likely that they're going to have a tension pneumothorax. If that was the case, and I felt that they were getting a tension pneumothorax, I would take the dressing off and let it, quote, burp if that's possible. Usually that doesn't happen because the tissue planes just kind of close up, and that is not helpful in any circumstance. Or just decompress them. Right. So that is my general thinking and approach. But before I laid down a definitive sort of, answer to your audience, I'd probably have to go back and do a very close look at the literature. Sure. I can tell you that even in the military, as far as I know, up till recently, we were still just putting occlusive dressings on penetrating wounds over the abdomen and chest. Yeah, and that's kind of why I asked, because. And, of course, we'll always give the caveat. This show is for entertainment and educational purposes. It is not we're not giving you specific medical advice or anything like that, obviously.
You should probably go to med school. Yeah.
Yeah. As Mike said, is stop being a wuss or whatever. Yeah. But I guess what I want the listeners to take from that discussion is, it's definitely maybe, right? And you see these little memes on Instagram, the little diagrams where it's you're going to put tourniquets on the extremities, you pack the junctions, and you put chest seals on the chest, and it's that's a good starting point.
That's where they go. That is true, but
yeah, and that's complete. The thing is, I can't tell you how many times I've gone to these scenes where my coworkers and they're doing the best they can. I'm not just knocking them for the sake of giving them a hard time, but a guy's got a little laceration on his wrist because he was trying to kill himself or something like that, and they're putting a tourniquet on it. And it's okay, bud, why don't we scan and holster that tourniquet there and just put a little bit of direct pressure on that bad boy? It's going to be just fine. Mm-hmm. So, I just like to get people thinking about some of that, because I know at the at some level, some literature is saying, and I'm specifically referring to the American Heart Association, first aid, Heart Saver first aid stuff is recommending to not apply chest seals because they're worried that people are not going to recognize a tension pneumothorax. So just something to think about. I've thrown that out there as a point of discussion.
Yeah, it's always hard because you have to know your audience. So when they're putting out stuff, it's obviously to a much larger, broader audience. If I was talking to my flight team of trained flight critical care, flight paramedics and nurses, it would probably be a little bit of a different conversation. Right. But that is true. That makes it a little difficult.
Well, it goes back to the scaling thing, I guess, is knowing your audience.
Speaking of your flight team, New Mexico, like a lot of rural states, mostly rural states, has a golden hour problem. And I used to face that pretty severely in eastern New Mexico on a bombing range. And in Afghanistan, Iraq, we talk about golden hour offset, things we can do to kind of cheat the golden hour. Is there anything that you do in New Mexico in a civilian context to kind of get there?
That is a good question. And I can tell you that I don't know if there are any specific things we are doing to address that. I will say recently, probably since even being in the military, my philosophy regarding the golden hour has kind of changed a little bit. We used to think of things in terms of time, like the golden hour. They need to be to surgical intervention within an hour and all that other stuff. And getting people to definitive care as soon as possible is important. However, what we've realized is, again, it goes back to the concept of time to meaningful intervention. And sometimes that intervention is putting in a chest tube or doing a finger thoracostomy. Boom. Now the tension pneumothorax is gone, and there's really nothing else that's truly lethal for this person. Maybe have a little more time. Or a whole gamut of things that I think we look at. And traditionally, we've just thought of it in terms of like, you have to get this done in 5 minutes or this done in an hour. But really, it's more like what do we really need to do for this person, and how can we get it to them as quickly as possible? I guess a more generalized answer to your question is trying to increase the capability of some of our flight teams and personnel so that we can extend the ability or basically push more advanced or procedures and capabilities out into the field, whether that's bringing blood or teaching them how to do more invasive surgical procedures, that type of stuff. In a non-trauma setting, what we're doing at this point is we're starting to be able to project our ECMO capability, putting people on basically percutaneous bypass for non-traumatic cardiac arrest, and being able to move it basically out of the hospital into the streets, or even flying it out to people in certain circumstances. So
this relates to something that we talk a lot about on the show, which is, and there's a couple angles to it. First, related to the golden hour, I think the most recent analogy that I've heard, and it sounds like you described this exactly, was the problem with the golden hour is that some of your patients don't have an hour, and some of your patients have plenty of time. And so it's just not that simple. He might only have 5 minutes, and he might be okay for several hours before it's a problem. And so where it leads us, and again, this is one of the common themes on the show, is critical thinking. And that's, Mike, it sounds like what you're speaking to is making sure that those frontline people are capable of thinking at a higher level, that they're learning beyond just the basic ABC, march thing, and they're understanding bigger picture what's going to kill the person. And I think that is a core part of our philosophy when we talk about, this people ideas, hardware stuff, is we have to go back to these human factors and figure out how we can more carefully analyze what we're facing and how to deal with it. So I like the way that you describe those things. Are there any stories or lessons from, I guess it doesn't have to be from the military, but of course war stories are always cool, but are there any stories or lessons that has affected the way that you approach leadership or teamwork now as an ER doc, stuff that you might have taken from your other experiences?
Ooh.
It's like human factors to the next degree, right? Now it's human factors of groups of humans.
I guess one of the things, if I were to say one major thing, is managing the cognitive bandwidth of the team. And what I mean by that is like you, me, whoever, it doesn't matter how smart you are, you can only process so much information and do so much stuff at one time. So traditionally, right, and even if you look at the ACLS videos and stuff like that, you have the doctor, right, running things and giving the nurses instructions and telling the paramedics to do this and having the airway person do that and all these other things, right? However, right, we think about intelligence in terms of training and degrees and letters behind your name, but really it doesn't matter how smart you are. You can only think about so much stuff at once, right? So why is the doctor simultaneously trying to, figure out what's going on with this patient and process their medical history and get the story of what happened and put together a big picture, 30,000 foot view and plan, and also organize the nitty gritty of telling the nurse to do this and making sure that there's good chest compressions and all this other crap. In reality, and this is one of the things I did learn from the military, that it's just not going to happen that way. You do not have the cognitive bandwidth, the ability to process all that information and still be able to keep on and make sure people get the right drugs and the right interventions, the right time intervals. And in fact, when we test it turns out that in basically across occupations, people just can't do it no matter how smart they are. So I think one of the lessons we've learned and one of the lessons we adapted is in pretty much like all of our cardiac arrests now, we try and have nurse captains. So we basically delegate all of the ACLS stuff to one of our really well-trained nurses, and not just like a recorder, but he or she will be like running things and like telling people when to give the drugs and basically doing all the ACLS that they're trained to do. And what does that do? Well, that allows them to take care of like the chest compressions and the meds and all the other stuff, and allows us to stand back and be like, I wonder what happened to this person. Like, why did they go into cardiac arrest? How do I solve that problem? What tests can I do? Can I ultrasound this person? Can I use transesophageal echocardiography to like look at this person's heart? Can I do this test or that test? Is it worthwhile to do those things at this point? Is this person just like a person that would not want to be resuscitated, or otherwise has instructions that say they would not want to be resuscitated? I can't think about all those things and run a code. So in terms of leadership, management, communication, and human factors, it's basically looking at like what your brain can attend to and what your brain can process, and then dividing up the tasks instead of just by experience or by whatever your job name is, thinking about it and saying, you know what, maybe these people could do all this other stuff and it would free me up to do X, Y, and Z.
Yeah, that's well put. I think the describing it as bandwidth is good, especially in the context of different scenarios require different cognitive loads, kind of like you described. In other words, one of the things that makes a SWAT team so efficient is that every individual on that team has their little slice of responsibility, and I can hyper focus on that door or that window or that, one thing. And because we all have a slice of that, I go into one of those scenarios 14 or 18 people deep or however many people deep. It's a lot more manageable than if I am just one person trying to see that entire picture. Mm-hmm. And when it comes to human factors, and I go back to the very beginning when we started talking about scaling, how do you teach differently when it's an individual person who's just a bystander, citizen, layperson type of thing, and then your law enforcement, public safety, you have EMT, paramedic, nurses, doctors, surgeons, you have the whole spectrum of different levels of expertise. The other way that I think about scaling it is, well, what happens when I'm trying to teach a police officer who now is in this scenario by himself, or maybe a EMT paramedic team who's on this call by themselves, and there's only one or two of them, how to find those priorities and have that cognitive bandwidth to problem solve. And I mean, that's, obviously I think we'd all be millionaires if we had the secret sauce to figuring that out. But I think they're good questions worth asking and trying to figure out what better ways we can manage that bandwidth.
Yeah, no, I totally agree.
One of the things that I've thought about lately is like, is there, we don't have an ABCs for law enforcement. Like in the medical community, we've got March, we've got ABCs, and that is a cognitive problem solving tool. And in law enforcement, going back to the overarching, mantra thing, you talked about speed, surprise, violence, action, or the other one you said was speed, simplicity, and
coordination of care.
Yeah, there you go. So those are good. And so if I need to try to think of ways to apply a similar model to like a cop on a traffic stop or a cop on a domestic violence call, So I think it's a interesting place to look.
Looking back, what advice would you have given Airman Lauria as about to go to MEPS or about to go to Lackland or about to go to Medina?
Ooh, that's a really good question. I don't know. Besides strap in, hang on, it's going to be one hell of a wild ride.
Damn, Skippy.
I guess if I were to give myself one piece of advice going back, it would be, don't be afraid to get into situations that scare you, make you uncomfortable, or otherwise really push your limits. Because it's really hard, especially, coming into the military or coming into a larger environment or changing jobs or changing cities or changing, you name it. Like, you can put yourself you can be in some very uncomfortable positions where you haven't done stuff before. You're worried about failing or screwing stuff up. But really, like, the best experiences throughout my career in the military and the best times that I've had out of the military have all come from really stepping out of my comfort zone and really pushing my technical abilities, working with a team that's actually way more proficient when it comes to weapon systems than I am. My weapons training, and marksmanship skill, went through the roof, working with the 10th Special Forces Group, for example. My clinical skills, stepping out of your comfort zone as a paramedic and going to work with some really super smart anesthesiologists and surgeons can be super intimidating as a paramedic. But if I hadn't have done it and really stuck my nose out there, I wouldn't have become nearly as good a medic in the military. And I probably wouldn't have been inspired to go to medical school. So I would just say, I would tell Airman Lauria to, feel free to step out of your comfort zone and really push yourself, because that's how you're going to grow and become a better operator and a better medical provider.
Yeah, I think that's good advice for anybody. Is there anything that you are working on now? I know you've been on several of the MCRIT episodes. You're a regular contributor, or do you help run that project, or what's your what do you got going on?
I am a lowly contributor. Scott is really the brains and the bronze behind the operation. I just contribute some of the human factor stuff and some of my thoughts on some of these things. To be honest, I am literally looking at on my whiteboard right now a list of topics that I've been either meaning to write papers on or write MCRIT posts on. And sadly, the list is growing longer, and the check marks are few and far between.
We understand. That's how this project started.
At this
was
point
exactly
in residency
that.
Training,
Yeah.
Our time we're pretty busy. So sleep is getting sleep and working out are luxuries almost.
They come at a premium for sure.
Yeah. So hopefully soon I will have a little bit more time to do some more writing and publish some more stuff. But right now I'm just trying to become a good doctor, I guess.
I'm sure you're doing good. And there's a bunch of videos on YouTube that I found. If you type in Mike's name on YouTube, you'll find a bunch of the talks that he's given, which are excellent. All right, guys. Well, before we go, we want to thank Point 6 for sponsoring the show. Point 6 has mastered merino wool, and their products outperform their competitors in tests that measure moisture and evaporation. Point 6 has a variety of socks available for every activity, and I honestly wear them every day at work. So go check them out at point6.com. It's point6.com. Remember that we push out new episodes on the 1st and the 15th, so subscribe if you want to stay in the loop. If you want to support the show, you can go give us $1 for new episodes on Patreon. We've also got some shirts and stickers up for sale on our website if that's your thing. And you can also go over to tacticaltangents.com. One of our new things we've added is a little microphone you can click on if you want to ask a question or leave us some feedback. If it's really good, we'll feature it on the show. Make sure you go find us on social media. We are at Tac Tangents, and we have our discussion group on Facebook, so you can interact with us there. Mike, Jim, you got anything else?
I'm grateful we got Mike on the show. Our goal is to elevate the conversation and is to work in that cross-domain space between military, law enforcement, concealed carry, medical, emergency, first responder stuff. And having someone who is that smart and that deep in his knowledge, being able to talk through this stuff and explain things that I've been trying to explain for years, hearing him just oh yeah, that's just what I do, is freaking cool. So I'm grateful for him.
Cool. Mike, you got anything else?
Thank you guys. Thank you guys very much for having me. And I would just echo that statement. I think we really, when we come together with very different backgrounds and exposure to very different things, whether it's, a background in business or technology or electronics or tactics or aviation or whatever, and we all come together and we discuss some of these topics, we get, I think, this premium blend, this sort of hybrid viewpoint on things. And I'm always impressed when I go to talk to people at different conferences or stuff that have different backgrounds. You're like, man, like I never thought about it that way. But just like Jim said, it's like that is exactly it. And I didn't even know that someone studied that, or someone wrote about that, or someone did this, because I think that's really when we expand our individual domains. So I think being on a show, we can talk about these things across multiple disciplines is really amazing. And I really applaud what you guys are doing. So thanks for having me.
Awesome. We appreciate it. And we appreciate your time. All right, guys, that's all we got. Good talk.